coming off. All right, guys, so this is it. This is where we remove. Hi guys, Dr. Barko here from Lexington Podiatry. You're about to watch one of my videos. Hi guys, Dr. Barko here. You're watching a mucoid cyst excision. Okay, this is a left foot third digit. See that tumor-like appearance on the top of the toe? That's a mucoid cyst. A mucoid cyst is a lot like a ganglion cyst, but it comes from one of the little teeny joints in the toe. These frequently, patients will come in, they'll be like, I thought it was a mosquito bite, and so I drained it, and it was sticky. Here I'm making my incision with my scalpel. So this patient also, she was like, I drained it, and this sticky jelly-like material came out of it, and I drained it. Well, after doing that so many times, for this patient in particular, it became almost like scarred. So this, no drainage is going to come out of this. So sorry to burst your bubble, literally, because, usually when I'm taking these out, they bust and you'll get some sticky drainage and whatever. We didn't get that from here. So it was pretty crazy to me that it was so scarred that this lesion stayed intact the whole entire time. So we do have a tourniquet on that toe, and the reason we do is for visualization. I cannot see the area if it's full of blood. So we're using a tourniquet, and we don't use tourniquets on certain patients who, can't have one. But so here I am dissecting all the way down to the joint. And it's not hard to do here because the skin is so thin. And basically what we're going to do is dissect this completely all the way down to bone into the joint and remove it. If you don't remove these like that, like if you were just to cookie cutter biopsy this, it'll come right back. So that is why we make such a big deal, and we actually excise it down to bone. The reason we're gowned and gloved here is because we're touching bone. So we are being very careful. The patient has been scrubbed. The area is as sterile as possible. Nothing sterile like an operating room, but, basically this is as sterile as we can get in an office setting. And we try really hard, and everybody knock on wood for me because we don't really have infections. Our patients follow our protocols, and we do a really good job about keeping the area sterile during the whole procedure. And because of that, we have really good results. Ooh, look, it's coming off. All right, guys. So this is it. This is where we removed. So now look at that big gaping hole. I mean, that was a large mucoid cyst on a really small toe. So I am going to lift the skin here, and I'm going to edge underneath it, which makes the skin a little bit more mobile for my sutures. It's not perfect. In fact, I can tell you, spoiler alert, towards the end of this, we don't get complete closure. I mean, it's fine. Oh, here's me taking a little extra out because I can see it. Yeah. Very cool. So if you don't get the whole lesion out, it can come back. And recurrence of these is about 50-50 anyway. Patient knows that going into this. So this is not a surprise for our patients. We are very transparent about postoperative issues they may have and postoperative recurrences, like bunions recur, hammer toes recur, ganglion cysts recur. Do we try for any of that? No, but sometimes that stuff happens. So, and we're going to put our suture in. We're using a 4-0 Proline, 4-0 because we're on a toe. And I also warn patients that because we're so close to their nail bed, this can affect their nail. Usually it doesn't. Usually it's totally fine. But I just like to warn them that that's a possibility, especially with patients who are concerned about the way their nails look and stuff like that. Some patients are more like that than others. So we just try to keep that in mind, when we're talking about postoperative complications with patients. So again, this is a mucoid cyst, which is similar to a ganglion cyst, but comes out of a joint. The only way to get rid of them is to excise them. If they don't bother people, we don't have to do anything to them except keep an eye on them. But this patient came in here. Look at me try to get this one closed. Ugh. mean, that's about as good as it's going to get. You're going to see, like, as we put more stitches in, like, I want it to be closer than that, but that's what we got. This patient's young. She's healthy. She's going to heal this wound. That's not going to be a problem at all, but you don't like to see that. Look at my good technique with my fingers on suture. Okay, so I was saying, I can't remember what I was saying, but we're going to put our next suture in because we're going to try to get as much closure as possible so that this wound can granulate in and heal over. I did warn the patient as well, when she comes back for her follow-up, she may not be getting those sutures out. That's a possibility. Sometimes I leave them in longer. So almost every single suture I put in a patient stays in for 14 days, give or take. Sometimes I leave them in for 21. I have left sutures in someone for 45, 90 days. I know that sounds crazy. They do not grow into your skin. People think that all the time, like, don't leave my stitches in, it's going to make it worse. That's not a thing. You would rather leave your stitches in than your wound pop back open. So, my videographer is making me a little dizzy. So, as I put this next suture in, you're going to see the wound closes down some, but it's still not perfect. I think before we were talking about recurrence and conservative care. So the reason we are removing this, and I had just met this patient. So I think we met her and then we scheduled her for surgery. That does not always happen. I make patients fail conservative care. Here's why. If you were my sister or brother, I would make you fail. I treat my patients the way I would treat my family. And that's one of the things we do here at Lexington Podiatry. We're not like, hey, cut on it because it looks bad. Like, we want to make sure that if we're doing surgery, we have a reason. Yeah, see that wound? It's not perfect, but we just didn't have a lot of tissue to work with because toes are so little. So all of that pinkish red area you're going to see is going to granulate in. I'll try to remember to take some post-operative pictures of this patient so we can post them in the comments under this video. That would be fun. That's probably what they want me to do. Yeah. So conservative care is key. If she had just noticed this mucoid cyst, I may have drained it for her. I would have definitely told her how to take care of it at home. And then if she came back in a year and was like, listen, doc, this isn't working. This thing hurts. And so her complaint at this point was, my shoes don't fit right. My socks feel weird. I mean, you guys saw that mucoid cyst. It was gigantic. So that's the reason, like, we took her right to surgery because she had already been draining it. Ooh, that's better. Look at that. So much better. She had already been draining it at home herself several times. And so I know any conservative care I was going to do for her, it wasn't really going to help her. So taking the risk of doing a surgical procedure for her was going to make her better. And if it comes back, which it absolutely could, we tried. And this is worth it to her. And most of the surgeries we do, I mean, I was trained in rear foot reconstruction and all those things that some podiatrists do. I do mostly forefoot surgery, but when we do surgery here, our goal is to allow that patient to walk right afterwards as long as it's okay for the procedure. Like, we want them to go about their daily activities as normal as possible. Like, I think this patient went to work the next day. I'm like 95% sure. Or she was going to go, if we did this on a Thursday, she's going to go to work on Monday. That's how we do a lot of surgery around here. We try to, like, get you back to normal activities right away. The only thing not normal is she can't get it wet, so she can't shower. However, we have cast covers, and some of our patients get really creative with, taking a shower. So look at that toe. It's white. It is dying. It wants air, and it's going to get air from blood flow because those oxygen molecules ride on red blood cells. And you'll see, look at it pink right up. Like, just sitting here, you're watching it get back to normal because it's getting its blood flow back. You may see some bleeding coming out of the incision. Here it comes. That is excellent. That's what I want to see. Do I want her to go home and bleed all over the kitchen floor? Definitely not. But I want it to bleed. Okay, so we're covering her with betadine. Almost all of my post-op dressings get betadine. It's an antiseptic drying agent. You'll hear me talk about it forever because it's my favorite. And I think at this point I'm saying to the patient, hey, I'm going to let you sit here for a few minutes because we want this blood to coagulate. And she's like, okay. And my girls will sit with her and keep an eye on her until we know that she's not going to bleed all over her car and her kitchen floor. But we want it to bleed. I mean, blood is good. If you're not getting blood to an area, it's not going to heal. So we're giving her a little extra cushion here because we know she's going to bleed. And that brown that you're seeing there is not blood, that's betadine. But to some patients, they get a little nervous because it does look like blood at times. And people think sometimes, especially the patients I'm doing surgery on, like, hey, your dressings are huge. Yeah, that's how I prevent infection. So guys, this was a mucoid cyst. Hey guys, thanks for watching my video. If you're not one of our YouTube subscribers, please subscribe to our channel and ring the bell. Thanks for watching.